obviously lifelong disorder, and the origin of PCOS is that the genetic hit is the first, and the fetal exposure to androgen, and the second hit is obviously obesity, insulin resistance, etc. In the earlier, younger age, it's acne, hirsutism, androgens. In the later age, it is obesity, insulin resistance. That's the way the PCOS paradigm shifts as the age shifts. I think the genetic hit is explained by Dr. Sharayu in our AMH lecture, that there is a genetic hit and the environmental hit comes after the birth and later years with insulin resistant obesity, and a polycystic ovary is manifested. We always see two kinds of polycystic ovaries, the obese ones and the lean ones. In the obese ones, it is the insulin resistance which is harming it. I'm going to go into a smaller detail of that. And in a lean polycystic ovary, it's mainly a genetic hit. And because of a genetic hit, they have large number of follicles, and because they have large number of follicles, their AMH is very, very high. And this high AMH is not allowing the FSH receptor to be expressed. So the FSH keeps low. If the FSH keeps low, the follicles can't grow. So the growth is hampered there. AMH, definitely the receptors are positive. They have a positive action, because AMH type 2 receptors have been identified in the hypothalamus. Now, why AMH should be there? Firstly, why AMH should be in the female, that itself is a problem, because it's such a paradoxical thing. Anti-Mullerian hormone should not be there in females, isn't it? She's all Mullerian factors there. But the science is, the reproductive biology is such. You have type 2 receptors in hypothalamus, and probably when the AMH stimulates them, the way the pituitary responds to GnRH changes. So to the given amount of GnRH pulse, probably more LH is released if that AMH receptor is working. That's the hypothesis which has been put forth. So lean PCOS are the worst ones with a very high AMH, a high LH, and a typical features will be that, but for obesity. So these are our scenarios: a high AMH PCOS, lean, tall, high LH, okay, and high LH could be with obesity, and there could be a moderate AMH. And this, according to me, is the best patient: obese and a moderate AMH, because you do a weight reduction, she will respond. In the lean PCOS, let's say she was lean and now she grows by another 5 kg. Her AMH is 16 and LH is 12. You say, reduce 5 kg, you will get pregnant. No, her AMH is not going to respond so fast. It will respond quite late. Okay, so you should know whom to tell weight reduction will give a pregnancy and whom not to tell. And you could have a polycystic ovary morphology with obesity and AMH moderately high, maybe about 4, 5, something like that. Well, this is the best client. You can tell her, just reduce weight, no need to come to me, you'll get pregnant on your own, because it's polycystic ovary morphology and a moderately good AMH, and weight reduction is the one which is causing anovulation. It is the insulin resistance. Treat her insulin resistance and she will do well. So AMH determines the severity of polycystic ovary, but unfortunately it is not a part and parcel of a diagnostic paradigm. So we looked at a paper, can AMH predict the diagnosis of polycystic ovary syndrome? And this is a systematic review which has been conducted. And they said that, well, if the AMH cutoff is beyond 4.7, you could be looking at large population of polycystic ovary patients. But PCOS is much, much heterogeneous a disorder. No single AMH can define polycystic ovary, but AMH can replace PCOM, which is very important in adolescent age. But in adolescent, you can't do transvaginal scans, so you really don't have any clue about polycystic ovarian morphology. Well, AMH is your surrogate marker there. Should we have age-specific levels? Yes. At 40 years, you can't say your AMH is 3.5 and that's why you are not a PCOS. No, a 40-year-old lady with an AMH of 3.5 is a PCOS. But a 3.5 AMH at the age of 20 is not a PCOS. So age-specific AMH cutoffs are needed, and you have to think individual counseling needs to be done that way. And the figure depicting that as the age advances, the AMH cutoffs could come lower and lower. And due to USG challenges, having antral follicle count cutoffs are different at different ages, and AFC keeps on changing, AMH is pretty stable that way, at least for 6 months to a year. So AMH's value is most used marker today for PCOS diagnosis. Can AMH be used to diagnose PCO morphology? Well, since we are taking it as a surrogate marker, and the cutoff is 3.2 then. If your cutoff is beyond 3.2, 93.5% sensitivity and 96% specificity for identifying polycystic ovary morphology, which is pretty good. So FSH rise has to overcome the aromatase inhibition by AMH to induce good amount of follicle growth. A normal woman, FSH level for ovulation induction will be 7.8 MIU. In PCOS, the FSH level required could be anything between 3 to 14. 3 for patients who are easy PCOS, you would say, young ones, not moderate AMH, high AMH, while the higher AMH ones will require a higher FSH doses. So pharmacokinetically, FSH injection max serum level is by 16 hours, the terminal half-life is 30 hours, and steady state is reached after 4 to 5 doses. Can AMH level predict the need for increased medication? So that is yes. Moment AMH is high, you require a higher dose of stimulation. This paper is saying 154 and others. And those extreme AMH high patients, extreme PCOS, we see more common in Indian population. This is a nice paper actually. What they did was they dissected a JCEM 2009 paper published by Richard Legros et al. On comparison of clomiphene and letrozole for polycystic ovary. And they said the geometric mean was of AMH of 7.35 for patients who are not responding to CC letrozole and was 5.54. So what I mean is, lower the AMH, better is the response. Higher the AMH, worse is the response. So just because she's a PCO with a high AMH, don't think I will give a low dose. PCOs require a higher doses. So what about high doses? Does AMH also has to do with something with a perinatal outcome? Extreme high AMH is responsible for preterm birth, and they have found that more preterm birth in this particular population. And possible biological mechanism could be it affects the endocrine system of the fetus, and it is pro-apoptotic and Mullerian system. AMH receptors are there on the myometrium, and they may limit the myometrial hyperplasia. So preterm labor in a high AMH population is pretty common. Again, we don't counsel our clients. But fortunately, what has happened in these 2-3 papers, they have seen preterm labors more common in obese high AMH patient and not a lean. So there is a confusion whether it is the obesity or the high AMH. So that has eased our path. We don't have to separately counsel. We'll just counsel the obese ones that you have a risk of preterm labor. What about LH pathophysiology? And this is quite interesting, isn't it? We want to know about the LH in polycystic ovary. And this LH in polycystic ovary took a storm about 2 decades back. And I was lucky enough to witness one conference where Roy Homburg and Richard Fleming were presenting, had 2 presentations. So Richard Fleming first presented a whole meeting on, he presented on what was Roy Homburg's paper and what was Richard Fleming's paper. We all use agonist as long protocol only thanks to Richard Fleming. He introduced the protocol to us, and the whole world followed it for almost a decade. Richard Fleming, interestingly, is not a doctor. He's no MRCOG. He's an FRCOG, but it's gifted to him, honored with an FR, not gifted, honored to be an FRCOG. He's a biochemist by profession. But his knowledge went up to such huge degrees and PhD and everything that he was honored to an FRCOG. He's a practitioner. He's the first one to put up a clinic in Glasgow, a private IVF clinic in Glasgow. So he kept on presenting that this, I thought, LH makes a difference, and Roy Homburg kept on presenting LH does not make a difference. To an extent, I remember reading papers on repeated pregnancy loss, RPL patients, you should do serum LH level on day 2. If the LH is high, it is at risk of having RPL. I think few of us might have read those papers, but then it all vanished. So the LH story has come up and has vanished. Let me just tell you how the whole thing is. So why is LH high in polycystic ovary? I'm just narrating all the reasons behind it. One, it could be a higher LH response to the given GnRH. The amount of GnRH remains the same, but the amount of LH comes out is higher because AMH has to do something there, because the AMH receptor has been identified in hypothalamus. There could be obesity. With obesity, adipocytes will secrete androstenedione. A high androstenedione, imagine the huge obese load, androstenedione will be very big. Androstenedione by the obese aromatase enzyme gets converted to estrone. Estrone, estriol, estradiol. Estrone is E1. Estrone is very weak, but collectively the amount of estrone is very high of the whole obese cells. And that estrone chronically stimulates the pituitary to secrete more LH, as we understood with proginova. So the LH becomes high. LH is not suppressed by estrogen and progesterone. We expect the estrogen and progesterone in the late follicular phase and the luteal phase to suppress the LH. Am I right there? But when the female fetus was in uterus, she was exposed to a huge amount of androgens. And that androgen caused attenuation of the LH responses to the steroids in her pituitary. And as she becomes adult, the same continues. So the estrogen goes high, progesterone goes high, but doesn't make a difference to her LH. LH just continues there. Sometimes, I'll come to that, obesity also plays a role. AMH is high because there is high AMH, there is no FSH action. If there is no FSH action, androgenic milieu remains high, and a certain amount of chronic androgenism secretes more amount of LH through an LH beta receptor. Insulin resistance, because of insulin resistance, you have insulin growth factor binding protein 2 decreases in the ovary. Because of that, insulin growth factor 1 increases, and that causes more stimulation of the follicles and androgenic milieu. Androgen, more thecal androgen secretion will be there, where IGF-1 directly with testosterone acts on the theca to produce more amount of androgen, and it adds to the follicular growth. So these are all the different mechanisms why your LH is high in polycystic ovary syndrome. No doubt, we had LH-FSH ratio as one of the diagnostic criteria in olden days. So there is an increased mean LH pulse frequency and amplitude. LH increases androgens, and that's why it is, PCOS is also called functional ovarian hyperandrogenemia. But high serum LH may not be the only reason of functional ovarian hyperandrogenemia, because if the androgen is increasing, LH is increasing androgen and the vicious cycle is established, a lot of obese polycystic ovary will have normal LH, but androgens could be high. So there is a desensitization of theca cell to LH occurs with rising LH, limiting the androgen secretion. So LH goes up, but the theca cells go under tachyphile axis. So in spite of the LH coming through them, it is not secreting enough amount of, high amount of androgens. But it is the hyperinsulinemia which is coming from the obesity or insulin resistance that allows this tachyphile axis not to happen. The theca cells escape that, and that's why the androgen production keeps on increasing. So obesity acts there, worsening the whole cascade of polycystic ovary. High LH could be abnormal sex-steroid feedback, which I just told you that LH pulse frequency is not sensitive to negative feedback by E2 and progesterone, and androgens attenuate the negative feedback of E2 progesterone, hence LH rises, as I just told you. The prenatal exposure to excess androgen is the one who sets the more LH release in response to normal GnRH pulse. The LH response to androgens in PCOS is biphasic. This is very important to realize. A chronic modest high androgens, they will increase LH, a higher LH release with a normal GnRH pulse due to LH beta upregulation. But a very high androgen will suppress LH. And that's what happens in our older women. When you give androgens, it will just suppress the LH, and then your follicular genesis itself gets affected. What about obesity? Is a peripheral increase androgens. Androstenedione, I told you this pathophysiology, how obesity contributes. So what are the important LH cutoffs to understand in our practice? When you say a lady suffering from low LH, that means less than 1.2 or 0.8, a threshold LH is anything between 1.5 to 9 IU. A hyper LH is beyond 10 MIU on day 2, day 3 of the cycle. Premature luteinization is high LH with progesterone beyond 1.5, and LH surge is when LH goes beyond 17. The LH surge has been defined in 3 fashions. 1, LH level beyond 17. Second, LH level 3 times more than the basal LH. And fourth definition is the third definition, which is accepted, most accepted by Irani et al. And it says that the LH is up and the E2 is low. So it is a retrospective definition. On day you do E2 LH progesterone, LH is normal, progesterone is normal, E2 is high. Next day, LH is high, E2 falls down, progesterone is still normal. This is your surge. Because with LH going up, the follicles get luteinized, so they are no more producing estrogen, so estrogen drops, and the progesterone comes the next day. And that is the Irani, and that's the most accepted definition by the Barbara Lawrence and Human Fatemi group in their papers. Now, the question is LH needed by endocrinologically normal women? Probably not in all women. In the morning I told you that even LH less than 1% is good enough. But then certain women during the course of stimulation will suffer these things like poor endometrial development. There could be a poor responder in spite of having a good ovarian reserve parameters or posidone 1, and sometimes the last stages of follicular growth is entirely dependent on LH. Okay. So this is the mechanism of action, that the resting LH levels synergize with IGF and growth factors, and they are much adequate for your follicular growth, and as I told you in the morning, the spare receptor this. But if you have an excessive LH, that will disrupt the granulosa cell gap junction, and abnormal oocyte maturity will be seen. What about the insulin story? What they did is they cultured the granulosa cells with testosterone-rich media, and they tried to find out if they can measure insulin in that. They could not. But then they cultured granulosa cells with insulin-rich media, but they could measure testosterone at the end of 5 days. That means insulin is a culprit of androgenemia. So never in a lady treat high androgens, treat insulin. There's no point giving OC pills and anti-androgenic medications before you start any stimulation. Rather, you are harming her more. Treat her insulin, androgens will settle down by themselves. What about weight reduction? It's a very difficult one. Nowadays, I don't insist for every lady to reduce weight because there's no point. You're delaying conception. So I give them options. It's a shared decision making. And the shared decision making is that you're obese is telling me you're endocrinologically dysfunctional, and I need to override your endocrine dysfunction by giving higher dose. If you're obese and demanding, give me only letrozole stimulation, I want to save money, I said your chance of pregnancy is pretty low. But if you're obese and you're okay taking gonadotrophins, I'm overriding your dysfunction and giving you a pregnancy. So IVF in obesity will override that, will do that. So your IVF is a quicker answer in obesity rather than going for a weight reduction, it's a longer time. The problem with obesity weight control is dropouts are very common. Most of the studies are having dropouts beyond 40%. Okay, and after they have to lose double-digit weight. So 10 kg or more weight reduction has to be there to make any difference there. So just reducing 4 and 5 kg doesn't make much of a difference. And if you're going for a weight reduction program and ovulation induction, the Richard Legros study has clearly told 18 months of ovulation induction and 18 months of weight reduction program, time to pregnancy was faster in ovulation induction regimen than weight reduction program. So don't get carried away and tell everybody to reduce weight. Look at her ovarian reserve, look at every parameter, and if she is somebody who will respond to letrozole, just keep giving her letrozole. I thought keep giving letrozole for even adolescent polycystic ovaries, girls who are not married. Why give metformins and, just make them ovulatory, yeah? So if she's responding to letrozole and she gets regular cycle, I'm saying, just keep taking 5 days a month, keep taking tablets for 1 year, don't make a difference. Just don't around. Okay, that's okay, But if they're indulging into those sexual activities, I can't help it. I can't give them letrozole in that case. Then I have to force to give OC pills. But I've come down on OC pill prescription even in that group. Okay, and letrozole works wonders. They're so happy. 5 दिन लेना, वो डॉक्टर ने 3 महीना treatment दिया. So this works well. Not obviously letrozole will not give ovulation induction for everybody. There would be bad ones. Young ones could be very, very bad, lean and bad. But at least even if their cycle comes every 40 days, they're happy about it. So I think worth trying. You try it out and let me know. So top quality embryos would be high only in women who are losing beyond 10 kg of weight. So is that going to happen? So best is to educate your client. Are you determined enough to do weight reduction in this particular fashion? That you reduce beyond in double digit. And well, then that can make a difference. But she has an AMH of 16. Don't even tell her this. Tell her, even if you reduce, I may have to still go ahead and give you others. So do not hesitate giving pharmacotherapies for your obese polycystic ovaries. Take help of that more than just, because any one of you having a cognitive behavioral clinic, CBT कौन करता है आप में से? That means we are not practicing obesity control in all this. Am I right? The CBT is the mainstay. Okay, आपको listen करके we go out, I'll eat a pani puri and then forget about the weight reduction. It comes and goes. And my wife is there, so I can't speak more. Okay, so you need a cognitive behavioral therapy there to have obesity control. If you're not able to implement that, at least take help of pharmacotherapy. That's semaglutide, liraglutide, obesity surgeries, worth doing all these things so as to reduce them. And if you're insistent, because after all, the pregnancy outcome depends on the weight and BMI, no doubt. This is the last 2-3 slides I'm doing. What are the follicular dynamics in polycystic ovary syndrome? 4 to 6 millimeter size follicles in PCOS ovaries secrete estrogen in response to LH. So it is LH receptor is already developed, unlike a normal ovary. So LH plus endogenous hyperinsulinemia both are responsible for this. And this rise in E2 maintains a low FSH, which in turn prevents further development of healthy follicles. See how the whole system is working. And what does LH do? LH secretes, gives rise to cyclic AMP pathway. And moments the cyclic AMP is increased, the follicle gets mature. So imagine a follicle at 11, 12 millimeter itself is mature. So it's not going to give you a good oocyte yield at the end of the day. And that's why poor response is a bigger problem in polycystic ovary patients than OHSS for that matter. OHSS can be simply tackled by giving an agonist trigger. So in a normal patient, they will have inhibin B and E2 will come from only the bigger follicles, and the FSH action will be there. But while in PCOS, inhibin B and E2 will come from all the follicles between 4 millimeter onwards. So the amount of inhibin B is less, E2 is high, and that will suppress the FSH activity, and the follicle further growth will not take place. What about metformin then? Lovely drug or a useless drug? You define now. So this is a nice paper, metformin use and rates of development of gestational diabetes mellitus in PCO patients. They said 13.4% women not taking metformin and 18.4% women taking metformin develop GDM. Okay, so GDM is not affected. By giving metformin, you are not getting GDM low, preventive metformin. GDM develops, then you give metformin, that's okay, that's the therapy. But to giving metformin a PCOS to lessen their GDM chances is not there. And this is a PREGMET-2 trial, which is an RCT trial, double-blinded, use of metformin to treat pregnant women with PCO. It was published in Lancet. Gestational diabetes, 25% in metformin group and 24% in control group. So no significant decrease in preterm birth as well. So what are you altering when you give metformin? Are you altering LH? Ille. Are you altering androgens? No. Are you altering AMH? No. You have to take metformin for 2 to 3 years with that to make some difference to the androgen. So metformin corrects only the metabolic story, but that even doesn't correct it very well, so that your GDM and everything goes down. Okay, so our use of metformin has come down in practice. We give metformin to a lot of adolescent girls just to regularize their cycles a little more. But then when I have pragmatic progesterone use versus metformin, I would prefer pragmatic progesterone use. To give an example, suppose this girl is having only 3 menstrual cycles in a year. Lesser the number of menstrual cycles in a year, more obese and more insulin resistant she is. So she demands metformin, am I right? Okay. But imagine you give her pragmatic progesterone, tell her take progesterone for 5 days, get menses, on the 40th day again take progesterone. So you are making her have 6 to 7 menstrual cycles in a year. That itself will correct her metabolic dysfunction. That itself will correct it, try it out. And pragmatic progesterone makes a huge difference. You just have to go through good counseling sessions and telling them. And it is so beautiful, you know. She says, in March I have an exam, 12th standard exam. Okay, get your period by 15th of February. Let me give you progesterone 1st February, 5 February, take it. You'll get period before 15th February. And then for 2 months you don't take period. You take your holidays, सब करके और June में वापस और एक बार menses लाएंगे. So you take the whole control, give the whole control by educating the girl into her hand, by giving pragmatic progesterone. That works better than giving metformin for a long time. Endometrium is affected in PCOS. We do find obesity with thin endometrium, bad PCOS, androgenic effects, HOXA10 genes, all that makes a difference. So PCOS endometrium, high E2, low progesterone is exposed to, imbalances there with apoptosis and cell proliferation, and androgens they also affect. Sometimes the androgens could be so high that the endometrium gets pseudo-decidualized and they can come to you with primary amenorrheas. Young PCO, a severe bad PCO can come to you with primary amenorrheas because the endometrium is pseudo-decidualized and your progesterone withdrawal is no more acting onto her. Okay, that can happen. High androgen associated with increased progesterone receptor isoforms and progesterone resistance. Progesterone resistance is pretty common. Androgens affect penopodes, etc., all that thing. Obviously, PCOS pregnancy has miscarriages, placental insufficiency, preeclampsia, all that is common. Thank you. But before I just retire, I just want to tell you one thing about progesterone resistance. I think this is well understood, not evaluated, and not managed. You have to be keeping your presence of mind all the time that a large chunk of your patients of IVF or whatever, they require higher progesterone than what we prescribe because they have progesterone resistance. Who has progesterone resistance? All adenomyosis, all endometriosis, all obese polycystic ovary, obesity itself, and 20% of the normal population. Then now look at your progesterone prescriptions. So that's why probably we Indians have hit the clock better than the Westerners, wherein we are giving our dihydrogesterone as well as vaginal progesterone. Okay, I think that's the right way to do it rather than just giving one story, because our women are metabolically bad, and a long-term cardiometabolism, metabolic problems, obesity, all that will manifest as progesterone resistance. So I use 40 milligrams of duphaston in my practice, not 30. I may be wrong, but I don't know how to look for and choose out the clients of progesterone resistance and give them higher dose and rest give lower dose. I don't know, I can't choose it out. And that's why I'll end up using a higher progesterone. Thank you so much. Thank you.